chronic occlusions of the left main. And I can give you some examples from my own experience. So if you look into our overview of the literature in Europe, of our Progress CTO registry, where we include most of the CTOs done in Europe, you see that the left main makes up about 0.5 to 0.3% of all procedures. So really a small number in a large registry. In the UNDS, the Progress CTO registry shows also over a longer period of time the number of cases just to be 0.45 cases, 0.45%. Mean patient age was 68 years. Most of them were a lot of diabetic, hypertensive, and 85% of them were post-CABG. So they were kind of protected left mains. A few of them were non-STEMI patients, and 3 procedures of them were ad hoc PCI. And if you look at the outcome, the success rate was 85% in that series of about 20 cases. And they had very long procedures, almost 3 hours on average, 2.6 gray and 190 cc for these patients. There is a small series from Spain looking at 5 cases, and importantly, they also looked into a 5-year follow-up. What happened to these patients in the longer run? So they had looked only at successful cases, and you note that most of them were, again, post-CABG patients. So all of them, actually, and all of them had at least a lima to the LAD. So the outcome in this series was quite good after 5 years. The rest of the literature doesn't tell us much. There are a lot of case series. Everybody who has done a left main CTO sends it to some small journal, and so we have maybe 30 case reports. But what we learned from these reports is, again, the majority of lesions were in post-CABG patients, and probably many of these CTOs developed as a progression of the coronary disease post-CABG. They were not pre-existent at the time of CABG. Non-CABG associated left main CTO is a rare observation, as it is most probably a lethal coincidence. So someone who has a CTO of the left main is highly likely to die if he doesn't see a surgeon early. So I took this opportunity to look into my own case files over the last 10 years, almost 3,000 CTOs done, and I found 10 left main CTOs, 0.3%. That's just in the range of the literature. And you see that all but one were post-CABG, and we could fix most of them antegrade. Only 3 out of 10 had to be retrograde. We did IVUS in most of them. We should probably have done it in all of them. But what is interesting, many of these are calcified, so we did rota in 3 out of 10 during the procedure. The success rate was 90%, that is, just as in the literature, or maybe slightly better. So let me share with you 3 examples. All of them are post-CABG examples. First, a typical example which is the problem of the post-CABG patient. Maybe the bypass doesn't go down, but the progression of the disease causes the problem. So this patient has a nice lima, he has a venous graft, but there is lesion from this obtuse marginal to the diagonal. So this area is no longer supplied retrogradely through the bypass and progression of the right coronary. And this is the left main. It looks like it's through, but it's all calcium. So there is indeed a complete occlusion. This is heavily calcified. So the patient received PCI to the right coronary in an outside hospital. Then they tried the left main and failed. and we took it on in 2018. You see that the occlusion is rather short, but it is calcified. So we started with a pilot 200 because in calcified lesions sometimes that helps. It didn't work, so we go to a Gaia 3 that passed. Microcatheter does not follow, but with small balloons we finally managed, and we had to go to rotablation. Here you see the passage of the Gaia 3. Here you see the rotor burr, 1.75, and this is the result after 2 science stents. Another case, 78-year-old, bypass surgery about 7-8 years ago. Lima to LED, arterial graft to circ. Progressive angina and myocardial scintigraphy showing inferior ischemia because he has a left dominant system. The bypass from the Lima retrogradely supplies the circ, but you see a tight stenosis at the takeoff of the circ, and the original graft to the circ, arterial graft, was down. So this is an option, for example, to go retrograde with a marker, but I hesitate to go through the Lima that is really keeping up the men alive, so I prefer to go antegrade here. And we enter here with a first Fielder XT, no passage, then Gaia next second. You see the Gaia next second taking a rather big bend, but going to the distal vessel. And our target is not the bifurcation, the left main. Our target is left main to circ, because the bypass to the LED will last until his last day of the patient. So the target is the circ. Again, we need to do rotablation and come up with a very nice result. And finally show you an example that was a real challenge, because this is, again, a post-CABG patient, a 70-year-old female. She had bypass surgery with Lima to LED. However, the Lima was gone. So actually post-CABG unprotected because failure of the surgical intervention. And the funny thing, as happens, she develops ischemic cardiomyopathy, and someone thinks, instead of fixing the problem, which was the left main occlusion supplied only by the right coronary, she gets a resynchronization device which doesn't help. So what I show you here in this case, because it was a very long left main, is that we use CT guidance. Here you see the contrast filling up to the distal bifurcation, and the rest was really no filling. So we had no idea where is the left main. So we had to kind of trace back the non-filled left main and mark it. And this helps when you see green line, that this is just looking at the course of the vessel. And this helped to determine this otherwise invisible course of the left main. Here you see the contralateral injection. Here is the distal cap, and the proximal CTO is completely occluded. So we go retrograde through the septals. We enter with a knuckle into the stump of the left main. Then we try to advance with a Fielder XT. And it looks like it goes into the aorta, but here on this view you see we are outside of the contrast. So actually it was not correct. We had to do something that we usually don't do, inject into the lesion, but it looked like we are on tracing on the right course. We needed a stiffer wire. We advance a Gaia 3. Let me just give me 5 seconds more, or 10, to pass through. And then the Gaia is free in the aorta. So we snare it and finish the case. But the problem here was the occlusion was very long. So this is a 3.0 stent. You don't have a 3.0 left main. So we go IVUS and increase and put a non-compliant balloon and puff. Because of the negative remodeling, this was too much of non-compliant, but we could fix it, fortunately, easily proximal to the bifurcation with a papyrus stent. So let me conclude. Left main CTOs are rare, probably due to the lethal effect of left main total occlusion. Most of them you find as post-CABG patients. The incidence in registries is 0.3 to 0.5%. Post-CABG, as I mentioned. Success rate is similar to the general CTO population, and many of the main CTOs can be treated from antegrade. It was 7 antegrade, 3 retrograde, but they often need calcification, modification, so we had 30% rotablation. Thank you for your patience.